Hello, everybody, and welcome. I'm Sarah Dash, President and CEO of the Alliance for Health Policy. We're so pleased that you are here with us today for our session on preparing for flu season and preventing another pandemic. For those who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the health policy community dedicated to advancing knowledge and understanding of health policy issues. The Alliance gratefully acknowledges the Coalition to Stop Flu for supporting today's webinar. And I am extremely pleased to kick off today's event in conversation with the current chairman of the Coalition to Stop Flu, former Senate Majority Leader Thomas Daschle. Senator Daschle, hello, thank you for being with us today.
Great to be with you. Congratulations on the program.
Oh, thank you so much. The timing is good. Senator, before founding the coalition, of course, you served in both the House of Representatives and the Senate, and you are the only Senate Democratic leader to serve twice as both majority and minority leader. So you have a lot of experience making policy for sure. Why have you chosen to focus on the flu? Why now?
Well, Sarah, healthcare has been an area that I care deeply about. I've worked on it for decades now, and the more I spoke with stakeholders in recent years, the more I became convinced that influenza policy was really one aspect of healthcare where improvement was not only necessary, but I think really achievable. And as you know, flu has two aspects, both seasonal and pandemic. Unfortunately, from a federal government perspective, we really don't handle either one of them all that well. It's astonishing to me to think that in an average flu season, we could see as many as 60,000 deaths in the US alone, in addition to thousands of hospitalizations and millions of illnesses. It's truly one of the country's most predictable public health threats, and yet I'd argue that the federal government doesn't treat this threat with the urgency that I think it deserves. And then secondly, of course, from a pandemic perspective, it's clear that our country really remains dangerously unprepared for an influenza pandemic. This week, we crossed a tragic milestone, as everyone knows. We've now lost more Americans to COVID than the estimated 675,000 Americans who died in the 1918 influenza pandemic. It's difficult to even comprehend, and yet I have to wonder how much worse the 1918 flu pandemic would have been in today's hypermobile society. So unfortunately, one thing can be certain, and that is that the next pandemic is going to happen. It's not a question of when, but it's likely to be something we're going to have to confront, perhaps even in our lifetimes.
Yeah, that's a really frightening thought. And, as someone who found out sometime this year that I had ancestors who actually died in that 1918 flu pandemic that I didn't know about, it kind of brings it home a little bit more. And of course, so many people have lost loved ones to the current COVID pandemic and to the flu. As we're in the midst of this, still very much in the midst of the COVID-19 pandemic, what do you think for you are some of the key learnings from the federal response as they apply to the influenza and other, infectious disease management, but particularly the flu?
Well, Sarah, one of the things that I came to realize is that we really have to create more of a collaborative effort, which is why we started the Coalition to Stop Flu in the first place. We think it's so important that all the different stakeholders work together to see if we can't find a way to coalesce around this challenge more effectively, and to take the key learnings that there really ought to be a clear organizational effort around. And so I would point three lessons that are pretty broadly applicable to influenza and other infectious diseases. The first is just pretty simple. There's no substitute for preparation. Our country has long taken a reactive rather than a proactive stance toward pandemic preparedness. And this means that when a crisis arises, we scramble to put funding and personnel in place. That's certainly what we did with COVID. But a pandemic response is not simply a switch you can turn on and off. You need a strong public health infrastructure. You need disease surveillance capabilities. You need partnerships with diagnostics and drug manufacturers and agile and responsive federal agencies with clear roles and responsibilities and strategic plans that can be taken off the shelf and executed. You need all of that. And 18 months after COVID, I fear we've only made incremental progress in any of these areas. So that's number one, just preparedness. The second and related lesson is perhaps an obvious one as well, but it's that state and local governments need to be vital partners in infectious disease management. We're currently paying a price for years of underfunding in state and local public health departments and laboratories, and I worry about what will happen when the COVID response funding runs out, and that will happen. It's exactly what happened after the H1N1 pandemic and contributed to the situation that we find ourselves in today. And then I guess I'd say third, just as the federal government needs state and local governments, the federal government needs the private sector as well. And therein lies this need for a coalition. Too often during the COVID response, the federal government was either too late or too conservative about engaging the private sector on things like testing and therapeutics. So infectious diseases impact us all, and the private sector is just critical in both preparedness as well as response.
Yeah, thank you so much. And we certainly saw some of that with some of the public-private collaboration in the response. So I'm hearing preparedness, state and local governments, and then ensuring that there's a partnership with the private sector. Yeah, and so speaking of preparation, I mean, what do you think? Are we prepared for a flu pandemic? And what are the top things we need to be considering to really stop it?
Well, Sarah, I really hate to acknowledge what I really believe, and that is I don't think we are prepared. I'd hoped that we would take lessons from COVID by recognizing that public health is truly a national security issue, and taking steps to make new sustainable investments in public health and pandemic preparedness. But unfortunately, it just appears that it's unlikely that anything is going to happen near the scale that is necessary. So what we're hoping is that our coalition and all the critical stakeholders in the infectious disease ecosystem can really help make the case to Congress and the administration, especially right now, that public health and pandemic preparedness does have a constituency, and we quite literally can't afford to let this moment pass us by.
Well, thank you so much, Senator Daschle. It's an important call to action. It's certainly a challenging one amidst all of the other areas of focus, but we're so glad to be here today to be able to bring focus on this important issue. And we have a really phenomenal panel of experts that is going to really lay out the issues for us in great detail, including what to expect for this upcoming flu season. Senator, I want to thank you for joining us today and for your leadership on this issue.
Well, thanks so much, Sarah, and thanks for your leadership as well, and look forward to working closely together.
Absolutely. Thank you.
Okay.
And now it's my pleasure to introduce, first I gotta go over quick housekeeping items, sorry guys, and then I'm gonna introduce today's moderator. So first, you can join today's conversation on Twitter at the hashtag AllHealthLive, join our community at All Health Policy, follow us on Facebook and LinkedIn. We want you to be active participants. Please get your questions ready. You should have a dashboard with a little speech bubble icon that has a question mark, and go ahead and use that to submit your questions at any time throughout the broadcast, and we'll get to as many as possible. And if you have any tech issues, go ahead and submit them there as well. Finally, please be sure to check out our website, allhealthpolicy.org, where you can find background materials, including a resource list and an expert list, as well as a recording of today's webinar and slide deck, which will be made available on our website soon. So now it is my pleasure to introduce our moderator, Dr. Amish Adalja. Hello, Dr. Adalja, it's so nice to see you.
Hi, thank you for having me.
Yeah, so Dr. Adalja, you're a senior scholar at the Center for Health Security, part of the Johns Hopkins University Bloomberg School of Public Health, an adjunct assistant professor and an affiliate of the Johns Hopkins Center for Global Health, as well as an expert in emerging infectious disease, pandemic preparedness, and biosecurity. And of course, as Senator Daschle made the point of public health really as a national security issue, We are so fortunate to have you with us today to lead our discussion. So I will now turn it over to you to introduce our panelists and lead the conversation. Thank you.
So thank you for that introduction, Sarah. I wanted to start off with just a few minutes of opening comments, just because I'm an infectious disease doctor that works on pandemic preparedness and emerging infectious disease, treating patients throughout this pandemic. And I thought I would maybe just give you some overarching themes to kind of think about during the rest of this webinar and with our panelists. So I think that we're here talking about influenza. And I want to just emphasize the fact that these are distinct infectious diseases, but there's a lot of synergy between them. They're both respiratory viruses. They're both spread efficiently from person to person. They both have a lot of disruptive effects. And I do think while there are differences, for example, COVID-19 tends to spare the youngest children from severe illness, which is very different from flu, where we do get a lot of pediatric mortality. There is a lot that we've done during this pandemic that has to be built upon. There's a lot of momentum that we've seen with pandemic preparedness, with COVID mitigation, that I think can form a basis for us to be much better with seasonal flu, because we still have tens of thousands of people who die every year with seasonal flu. We have poor vaccine uptake. We have healthcare workers who don't get vaccinated against flu. And a lot of the energy around COVID, I think, can be harnessed and moved towards flu. And it's going to make us all better. It's going to be so much better for all of us if we have even a more milder flu season. And there's a lot of uncertainty about the flu seasons coming up. And I think that's something that we may talk about in the discussion. But it's really important that we don't lose this moment, because pandemic preparedness, as Senator Daschle has said, has been often handled in a reactive manner. We need a proactive approach. And I think right now, since everyone's lives have been touched by this pandemic, we will be able to at least get them their attention to see how important public health is, how important infectious disease preparedness is, and how it can impact national security. I mean, you can just look and see how COVID and flu interacted just by looking at what happened to our flu seasons in the last 2 southern hemispheres and now coming up 1 northern hemisphere season and another northern hemisphere coming, that we basically had very little flu. And I think that shows you that there are ways to put mitigation measures in place and to give people harm reduction principles. It doesn't mean that we have to have everybody wearing masks during flu season, but we see that actually works, or social distancing or hand washing, how that can impact flu. So there's a lot to learn. And I think it's going to be interesting to see how flu preparedness builds upon what COVID-19 has done and where the differences may be. But the main point is there is a lot of synergy that I think would be important to remember and to use as we start to think about what flu is going to look like in the coming years. So with those brief remarks, I want to start to introduce this esteemed panel of experts that are going to help us dive deeper. First, I'd like to introduce Dr. Anand Parekh, Chief Medical Advisor of the Bipartisan Policy Center, where he provides clinical and public health expertise across the organization. Next, I am pleased to introduce Dr. L.J. Tan, Chief Strategy Officer at the Immunization Action Coalition. Prior to joining IAC, Dr. Tan was a Director of Infectious Disease, Immunology, and Molecular Medicine, and then Director of Medicine and Public Health at the American Medical Association. Finally, I'm joined by Ms. Jennifer Miller, Treasurer of Families Fighting Flu. It's a good Twitter account to follow. I follow it. Jennifer joined Families Fighting Flu in 2013 after her young daughter's frightening battle with flu, a story you'll hear more about today. Jennifer and her family also established the Caroline Miller Endowed Fund for Nursing Education and the Katie and Caroline PICU Award at the Children's Hospital of Philadelphia to support continuing education for nurses. We're going to start today's discussion hearing from Dr. Anand Parekh, who will be providing an overview of the federal government's flu ecosystem. Dr. Parekh, I turn it over to you.
Thank you, Dr. Adalja, and thanks to the Alliance for Health Policy and Sarah and everyone who has organized this important webinar today. So many important themes that Dr. Adalja has already covered. I think from my perspective, when it comes to seasonal influenza, we can no longer take this for granted. As we've heard, and you'll hear, tens of thousands of Americans in a regular flu season die from seasonal influenza, hundreds of thousands of hospitalizations. And I think for pandemic influenza, I think it's not a question of if, but when. So both of these topics are absolutely critical. And I think seasonal influenza preparedness helps us with pandemic influenza preparedness as well as vice versa. So I think it's something important to acknowledge at the outset. When we think about the federal government and sort of the ecosystem of activities with respect to flu, there are so many critical agencies from the CDC to the FDA to the NIH, ASPR, and BARDA that are involved. I think the easiest way to sort of categorize this is to really think about sort of the prevention, detection, and treatment when it comes to seasonal influenza. Certainly on the prevention side, there are many agencies involved with vaccine-related efforts, whether it's clinical trials at the NIH, whether it's increasing domestic manufacturing capacity through ASPR, as well as BARDA. There's the procurement and the purchase of vaccines that's done through the CDC, through programs like Vaccines for Children and other programs that purchase vaccines for vulnerable Americans. Obviously, CMS through Medicare and Medicaid are important purchasers to get to tens of millions of Americans. And then there's promotion of the vaccine that is done by CDC, CMS, and other federal agencies. On the detection side, there are numerous agencies that work there. Obviously, CDC has an important role with respect to surveillance. That's global surveillance, tracking the circulating strains, as well as domestic surveillance and looking at the integrated influenza surveillance network to help us assess where we are with cases, hospitalizations, and deaths. And then, of course, with respect to detection, testing is absolutely critical. And there are a number of agencies there that have an important role, from ASPR and BARDA and the work they do there with advanced research and development, as well as an FDA from a regulatory perspective, ensuring tests are safe and efficacious. And then finally, from a treatment perspective, again, ASPR and BARDA and FDA for antivirals have a tremendously important role. And then looking at the healthcare system at large, ensuring that hospitals are prepared, that their surge capacity, beds, as well as staffing, ASPR plays a critical role there. So as you can see, all of these agencies really work together. They have important roles, both domestically as well as global. Some agencies like CDC, of course, provide important support to state and local health departments who work on all of these different types of issues. So there are a lot of different functions across the federal government, but I think I want to probably end on what I consider probably three of the most important priorities at the federal level. These are priorities right now, but I think these need to be the three priorities for the federal government as you look at the flu ecosystem moving forward. And the first is certainly that we need better seasonal influenza vaccines. And I think has already been alluded to, the current effectiveness rate, if you look at over the last decade, the effectiveness rate of the flu vaccine has ranged from about 20 to 60%. I think, and we can all agree that we want to do better there. There's a lot of important research right now at NIH looking at a universal flu vaccine that could work with multiple strains, that could be effective for kids as well as adults, that could provide some long-term immunity, at least a year. I think that's an important development. There are many who are talking about using the mRNA platform that several COVID vaccines have used for flu, and whether that's a possibility in the future, so that we can get a more effective flu vaccine as well as a faster vaccine. So better flu vaccines, I think, are an important priority. The second important priority is just to increase the uptake rate of a seasonal influenza vaccine. Over the last decade, if you look at uptake rates, they're usually at around 40 to 50%. So certainly an area that we want to do better with respect to promotion. Of course, vaccine hesitancy plays a role there, and I'm sure that's a topic that we're going to be talking about, but that's an important area for the federal government. And then third is just continued pandemic preparedness. And there are many agencies in the federal government that have an important role there. ASPR has a critical role within Health and Human Services. ASPR recently released a National Influenza Vaccine Modernization Strategy, which also relates to pandemic preparedness. The current White House has recently released a robust $65 billion pandemic preparedness plan that has many important elements. The CDC, as you know, is moving forward with a new National Center for Epidemic Forecasting and Outbreak Analysis. So there are many important developments there at the federal level. I'll just end by saying, most recently, the Bipartisan Policy Center, one of our task forces, released a set of recommendations related to positioning the public health system for the next pandemic focused on increased intergovernmental coordination, shoring up our public health data infrastructure, and financing our public health infrastructure. But one recommendation there related to having a national board on pandemic preparedness that could set some metrics to assure that we're prepared, gauge how we're doing on an annual basis, and then report to Congress. So again, I think focusing on pandemic preparedness, pandemic flu preparedness is absolutely going to be critical as well. So those are a couple of opening remarks on the important federal role vis-a-vis seasonal as well as pandemic influenza.
Well, thank you for that overview, Dr. Parekh. Now I'm going to turn it over to Dr. Tan.
Thank you very much, Amish. Appreciate that. And I just want to follow up on what Anand had just said, and this idea that annual readiness in terms of influenza vaccination equates to pandemic preparedness. And I think that's something that I think we need to keep emphasizing as we now shift the conversation to talk a little bit about seasonal influenza. Next slide, please. So just to remind everybody, and this has already been mentioned by the Senator, thank you so much, Senator Daschle, again, for your interest in influenza. We talk about this illnesses that's at the bottom of that right-hand pyramid, a number of illnesses that occurs every year as a result of influenza, and this is the burden of influenza over the last 10 years. But I think on top of that, we want to remind ourselves of the hundreds of thousands of hospitalizations and the tens of thousands of deaths that are resulting from flu. And I think we want to remind ourselves that while we look for a better flu vaccine, and absolutely, and then I agree with you, we want the better flu vaccine, we have a good enough vaccine right now that we need to keep using, because that flu vaccine while it may only be 20 to 60% effective at preventing those illnesses, it is incredibly effective at preventing the hospitalizations and deaths in the event you get flu and you've been vaccinated. And then the other thing I want to remind everybody also is this concept that, adults over 65 account for a lot of our hospitalizations and a lot of our deaths. So next slide, please. So what I want to talk about quickly with regards to conversations about vaccine effectiveness is this idea that with the older adult, the conversation should not just be about preventing illness, it should be about improving quality of life. If you look at this frailty index, it talks about how when you get older, you begin to decline on this index towards the bottom where you're in a walker or in a wheelchair. And the goal of obviously our preventive care is to prevent you from going down the slide. And thanks to Janet McElhaney for sharing this slide with me. So if we're talking about this, next slide, please, and we're trying to prevent someone from sliding down that frailty curve, we want to be able to say, hey, if we want to talk about keeping your glass half full with exercise and diet and smoking cessation to keep you going up this curve, we need to add influenza vaccination there as well. And what I often like to say is, if you don't get your flu vaccine this fall, are you willing to risk your independence this winter? Next slide, please, Tracy. So what are we expecting this upcoming flu season? As you've already kind of heard from our wonderful speakers already, flu will likely be back. And the reason for this is, as Amish pointed out, COVID mitigation measures worked, but they've been relaxed, as many of you know. And with the relaxation of these COVID mitigation measures, we're going to have resumption of flu season. And in fact, we have warning signals. Other respiratory pathogens, such as RSV, that disappeared last season, they're already coming back. Now, that said, we have no idea how severe this next flu season will be, although there is some speculation it could be pretty bad because of the lack of the environmental boosting that we would have seen last season, but we didn't see it because we didn't have flu, right? So we didn't get that engagement with the pathogen or the disease. And so as a result, our immune system may be less ready this upcoming fall, but that's speculation a little bit. But what I'm not going to speculate is I think influenza and SARS-CoV-2 viruses will likely co-circulate. You'll likely get co-infection with both. And when you have flu on top of SARS-CoV-2 Delta variants at the same time, as already heard, this will likely increase the burden on the healthcare system. It will result in illnesses, hospitalizations, and deaths. Next slide, please. So where are we? We're back to this whole idea of hashtag avoid the twindemic, hashtag take flu off the table again, because we said this last season, we're going to say it again this season. These overlapping high-risk conditions using flu and COVID-19 that Amish talked about makes it critical that we protect against both flu and COVID-19. They are both vaccine preventable diseases, and importantly, they are both vaccine preventable deaths because the vaccine is extremely effective at helping you not die from these diseases. A twindemic of flu and COVID-19 will create surge capacity issues for our healthcare systems. But we do know from the previous season that if we have a strong, unified national message to seek flu vaccination, we can improve vaccination coverage rates. So what does that mean for all of us, right? We need to emphasize that after getting COVID-19 vaccine, you're not done yet. You need the flu. And vice versa. If someone comes in for flu, you're not done yet. Have you thought about the COVID-19 vaccine? And in order to accomplish getting everyone vaccinated, we need to have varied and innovative access points so that people can get vaccine at multiple locations. And then for flu in particular, we need to remember that flu vaccine given into December and January, as stipulated by the CDC, is still beneficial. And so we need to keep vaccinating until every dose of flu vaccine is administered. So we do not want to stop after Thanksgiving. We want to keep on going. Next slide, please. So this is the three-pronged approach to combat flu this season. I'm going to wrap up with this. You want to vaccinate to prevent flu illnesses, hospitalizations, and deaths. We know that works. But then if someone does get flu, we want to treat with the antivirals promptly, especially if that person has a high-risk flu condition. And then finally, we want to continue all the everyday infection control interventions that we've been doing, right? The things with staying away from others if sick, covering your coughs, wearing masks if that's what your local government is recommending. We know that works. Next slide, please. And so finally, I'm going to leave this up as I wrap up and just talk about the four myths that I address here on this slide, but there are many more that we can talk about in the Q&As. And so just you can take a look at this about whether the flu will give me the flu shot. We know that's not possible because it's made from inactive viruses or viruses that are not infectious. I'm healthy. I don't need the flu shot. Hey, as the vaccine, as the senator has already told us, many people die every year from flu and many more get sick. I've never had the flu. Every year, up to 20% of Americans get the flu. So do you want to run that risk again, rolling the dice? And then, of course, as we talked about, the flu vaccine doesn't work. We know what we talked about with effectiveness. It's not just about preventing illnesses. It's about preventing hospitalizations, deaths, and improving quality of life, especially for those over 65. So thank you so very much for the attention, and I will turn this back over to you.
Thank you, Dr. Tan. Now I'm going to turn it over to Ms. Jennifer Miller.
Jennifer, I think you're muted on your earpods. Thanks.
Yes, I'm sorry. Can you hear me now?
We can, thanks.
Okay. I became familiar with families fighting flu after my healthy 5-year-old daughter became critically ill from influenza. And if you wouldn't mind sharing the next slide, I'd sure appreciate it. The following slide. And I just wanted to share a little bit about my daughter, Caroline. She was a very active and healthy, physically fit 5-year-old. She swam 5 times a week in hopes of making it on the same competitive swim team that her older sister Katie was on. And she truly had never been sick. The only time she went to see her pediatrician was for well visits and routine vaccinations. However, on a random afternoon in December of 2012, what started off as minor sinus congestion and light cough turned into labored breathing. And in just a matter of hours, she would need to go to our local ER, where she was diagnosed with influenza A and double pneumonia. After diagnosis, we were told shortly thereafter that she would need to be transported yet again to another hospital, one with a dedicated pediatric unit. And once there, Caroline's condition deteriorated rapidly. She was beginning to have difficulty breathing on her own, and there was discussion of intubation. And for better clarification, I remember calling our pediatrician and just saying, hey, they're talking about the possibility of intubation, and I'm getting quite alarmed and quite scared, and I'm not sure where to go from here. And he said, I know I've been on a phone with them for the last hour, and I'm in the parking lot. And the reason I share that with you is because I can remember being so touched that he would come and leave his busy practice in New York City and drive in busy New York City traffic to get to us in New Jersey. But after I'm having that thought, I'm thinking, okay, why would he come do this unless we were in a dire emergency? It was at the same time that my husband also trying to have a better understanding of what was going on because things were moving so rapidly, that he stopped the chief of pediatrics in the hallway and he said, "Sir, can you please explain to us what's going on here? I think there's a misunderstanding. Our daughter Caroline is here for the flu." And the doctor turned to him and he said, "Sir, over 50,000 people die of influenza each year." And he walked away. And I just remember feeling like the oxygen had been taken out of the room because I had never in my entire life heard that statistic. And I had no idea that the number that would affect young, healthy individuals, let alone someone like my child. Caroline was in need of an oscillating ventilator, a special machine that was only available at 2 larger children's hospitals in the area. And so she was airlifted to Children's Hospital of Philadelphia in the middle of the night without her mom or dad, but instead with a team of strangers that promised they'd do everything in their power to keep her safe. And the list of what Caroline was facing was long and frightening: double pneumonia, sepsis, hypoxemia, impending cardiorespiratory failure, and she would spend 2 weeks in the CHOP pediatric ICU fighting for her life, all as a result of flu. Caroline had been vaccinated against the flu every single year except for that particular year. The flu vaccine wasn't readily available in the early fall of her school year, and once the busy first year of kindergarten began, I fully admit it fell off my radar, and it's a mistake that nearly stole my child's life. Caroline, I'm happy to report, made a full recovery, and without a doubt, her survival is by far like being on the receiving end of life's winning lottery ticket. But admittedly, it's a hollow victory when you realize how many other well-deserving and well-loved individuals do not receive the same happy ending. I'm incredibly thankful to our pediatricians and all the forward-thinking doctors and nurses for ultimately placing Caroline on the path that would give her the best chance to survive this terrible disease. But simply relying on luck and close proximity to an adequate medical center and getting seen by the right people at the right time is not any way to combat influenza. It is not a game you want to play. Next slide, please. So the slide here shows the day that Caroline actually came out of her drug-induced coma. And to LJ's points, even once somebody comes out of recovery, it's a huge recovery afterwards. And so just to highlight that, Caroline lost over 50% of her muscle mass. She was unable to walk assisted for about a week or 2, which again is nothing compared to what some of our other families from families fighting flu deal with, which is the ultimate loss of their loved one. But we share these stories to let other people know what we didn't know. I was raised in a family of medicine. My father was a pharmacist and my mom was a nurse, and we as a family wholeheartedly believe in vaccines, including the influenza vaccine. Yet I had no idea how important the timing of the flu vaccine was. And I most certainly had no idea that anywhere between 12 and 60,000 people die from contracting the flu each year. And that number includes young, healthy individuals like my daughter, Caroline. That's why it's so important for each of us to share this information with our families, our friends, our coworkers, our patients, every opportunity we get. One thing that we try to strongly impress upon others is that a recommendation is unfortunately still a recommendation. So any chance you have an opportunity to discuss it with your friends, if it comes up in conversation, make the indication that yes, every year you must receive your flu vaccine, and specifically healthcare workers. You're such a trusted individual. Please make that recommendation every time you have a patient in front of you. It means so very much. As I sat in Caroline's hospital room for days, I kept asking myself, how did we get here? How is it that I live in an area with some of the greatest hospitals in the nation, and yet my child is clinging to life? And at that very moment, I made a promise to myself and to my child and my family, and ultimately my God, that I would do everything in my power to get the word out about the importance of getting vaccinated annually. By sharing my family story, it's my great hope that another family doesn't experience what mine did. Next slide. And this slide just illustrates, it's a collage of just some of the families that are a part of the organization. These pictures illustrate that flu does not discriminate. All of us are at risk from flu, regardless of age, ethnicity, lifestyle, or gender. And our goal is to share our stories in hopes of preventing these tragedies from happening to other families. Next slide. And this is just a sample slide of some of the posters and educational toolkits and flu fact sheets that we offer on our website. They can all be digitally downloaded, or you can order them. And we use these in school clinics. We use these in doctors' offices. We have companies that try to utilize our deliverables even in their offices in order to vaccinate their employees. But you know, it's just imperative that the public must be educated and reminded that flu is a very serious and highly contagious disease. And I really just try to remind people that we have the power to protect ourselves, our loved ones, and our communities. We have the power to protect our health by doing one simple thing, and that's by getting our flu vaccine each and every year. It's safe, and it's the most effective way of preventing flu, and ultimately flu complications that can lead to hospitalizations and even death. I so appreciate your time this afternoon.
Thank you so much, Jennifer. Now we're going to take some questions from the audience. Remember, you can use the questions panel of the audience interface to submit your questions at any time. And while the questions are populating, I'm going to start with a few of our own key questions that we want to handle. And the first one I think that is interesting because I kind of hinted at it earlier regarding what the synergies are between flu and COVID-19. And I think I'd like to start by just asking the panel, is there now a brighter future for flu prevention and mitigation? How can we continue to support advancement and innovation after the urgency of COVID-19 has subsided? I think this gets to that momentum, all the efforts that have been put in place with diagnostics and vaccine outreach. How do we keep that going? So anybody want to start with that?
Anand, do you want to go?
Sure, I can start us off by just saying, again, I think it comes down to, it's not a question of if, but when, but we need to be ready for the next pandemic, and we can't lose this moment. All the gains that we've made in terms of vaccine manufacturing, surveillance, detection, all of that can be and should be used for flu preparedness as well. I think we've learned a lot of lessons from COVID. Some of these are the importance of non-pharmacologic interventions like masking and social distancing, particularly during a pandemic, and that obviously influenced flu season last year as well. We're learning a lot about the importance of vaccines, but vaccine hesitancy is probably another area that that concerns me. I'm concerned that some of the vaccine hesitancy with respect to COVID may have spillover effects with respect to flu, and I think we need to redouble our efforts to really ensure that we promote flu vaccine, because as LJ and Jennifer have said, the flu vaccine absolutely saves lives and reduces hospitalizations.
Yeah, I agree with that. Yeah.
And Amish, if I could just follow up on that, I think there's also a lot of, well, we've already spent a lot of money in building an infrastructure for immunizations because of COVID-19. I think the goal here, and there are bills out there now, is to sustain that infrastructure, right? To not to pull everything back when the crisis disappears, which is kind of what we did when we had 2009 H1N1. We built an infrastructure and then we pulled it away. And so I think we want to maintain and sustain the infrastructure that we've built here, because not only does it work for COVID-19, as you've already all suggested, it works for flu and it works for all the other vaccine preventable diseases that we still need to get into our adults, our adolescents, and our children as well. So I think sustaining this momentum is incredibly important with some of the bills that are going to the Hill in some of the infrastructure bills as well. So I think that's really important to consider.
I would just add as moderator's privilege, the clinical testing paradigm, I think, is something we want to continue. We want to get better at diagnosing flu because that links people to antiviral therapy. That gives us better surveillance. And this is also true for other respiratory illnesses. We've got to move out of this idea where we don't care what respiratory virus somebody has because maybe they're going to get better. We want to know. And I think we've got to keep up the momentum with the home tests, which we have now for COVID. They need to expand to flu and to other respiratory illnesses. I'm now going to take an audience question. This one says, Carolyn's story is powerful, but the issue is the response that it will never happen to me, which my son-in-law finds so rampant in his congregation in Coeur d'Alene, Idaho. For those folks, facts do not matter. In fact, they feel facts have a liberal bias. What can we do? I think this has become the story, not just with flu, but also with the pandemic, that this is very difficult to get through. It's kind of a new paradigm we're facing. Any thoughts from the panel?
Yes, I think that's why it's so important to share the stories, the personal stories, whether you're a doctor with a patient or even sharing it with, when we leave this call today to share, you'll never believe I heard this story today. And it seems like such a silly thing, but it's something about a story with the data that is completely compelling, because oftentimes it's why I shared photos of my child. That's not something I typically do with strangers, but I want them to see, do you see this as a healthy, very vibrant child? And if your child's 5, maybe that resonates with you, that, I have a kindergartner at home. Or our other stories where it's a 36-year-old mom that vaccinated her children, but didn't vaccinate herself and ultimately lost her life. It's sharing the story with the data that makes it that much more powerful and that much more memorable, because I'm just speaking from layman's terms. The numbers are very important, but we tend to forget a number, but a face lasts forever. And I really think if you can impress upon them that this is a human being just like your family members, whether it's your child, your mother, your grandfather, across the lifespan, that's what I feel like hits home and has a little bit more weight.
If I can also just jump in on that, I mean, we've been wrestling with vaccine confidence issues, but this what's happened with COVID-19 has really reminded us about the power of combining the story, as Jennifer said, but with the data, right? I think this is the thing. When we started with vaccine confidence at the very beginning of this whole issue, I think what we as academics, public health advocates, clinicians, physicians such as you and Anand are, we've said, we can't believe that people will believe a story that's not truth, that's not based on facts. But I think what we forgot was that a story can be inaccurate and will still change minds, and a story can be totally non-factual and will still move people. And this was really hard for us to accept. But I think now we're reaching this really fine balance of what Jennifer's suggesting, that we have our stories so that we can move people and change minds, but our stories are founded in fact, whereas theirs are not. And I think this is something that we need to continue to leverage.
I'll just briefly add, I think it's the message and the messenger, and in this case, Jennifer's, powerful story based on her experience. But as you all have said, healthcare professionals, faith-based leaders, friends, families, community-based organizations, the message coming from them, trusted messengers, are absolutely critical in conjunction with that message.
I always say to people that the facts, logic, reason, rationality are always on the sides of the vaccine. So that gives us the kind of the biggest advantage when we're in these kind of debates or when we're talking to people who are vaccine hesitant. It's just about showing people the data and the way that they can actually appreciate it. So I think the next question I'm going to ask is something I think we hinted at a little bit, but I want to talk a little bit more about. So I think, Anand, you talked about that their vaccine hesitancy may be bleeding from COVID into flu vaccines. And in my knowledge, I don't think during this last flu season, which was pretty mild, that we had a big drop off in flu vaccination rates. I don't know if we've got the data, but my in general impression was that we did pretty well this last season when it came to flu vaccination rates. But have we seen any drop off, or what do you predict will be the uptake to the panel of flu vaccine now in this post-COVID situation?
That's a great question, Amish, and I just asked that to LJ right before today's webinar, and I hope you're right, and he can probably respond. My concern is that the politicization of the pandemic has increased even from the last year, and again, we need to get the message out that Amish, as you said, COVID as well as flu are two separate and important infectious diseases that are vaccine preventable. that we need to make sure that all eligible Americans, and for flu, that's everyone over the age of 6 months, gets their vaccine. So I think it's just ensuring that we have consistent messaging. But I am a little bit concerned about this year, given the vaccine hesitancy we've seen with COVID. And again, that's why these kinds of webinars and discussions are so important to get the word out.
Yeah, and I think to add to that as well, it's one of you mentioned that it's not just the message, it's the messenger that's every bit as important. And I think depending on who the messenger is, whether you said it's a trusted leader in the community or it's a doctor, I think a lot of times the hesitancy can be combated with just asking questions, because I think we hear a no or I don't want it, and then we kind of cancel it off our list because we know there's so much work to be done with people that are open-minded. But honestly, a lot of times just a discussion to understand what are their concerns, asking the extra question and giving them a chance, because really we're all coming about it from the same angle, right? Ultimately, everybody wants to keep their family and community safe. So, perhaps asking those additional questions and being able to answer them effectively with science-based data, that would be extremely helpful.
Yeah, I think that's I don't have much to add to that, except to say that this whole idea that we're using this concept of motivational interviewing for a lot of our clinicians now, because I think it's really important to not just try to spew facts, because we know that that's not enough, right? And so the idea of motivational interviewing is this concept of listening with empathy, right? I love the statement. You want to listen not to respond. You want to listen to understand. And I think that's so fundamental. If our clinicians are listening to understand, then they can get to the motivations of why someone is saying, I don't want the flu vaccine. And then that will then help you get into there. And finally, the idea of motivational interviewing is that you then empower that patient to make that decision. Based on you being empathetic and listening to me, I am now listening back to you, and now I'm deciding these are the things I'm going to do to get my flu vaccine. So I think you're absolutely right, Jennifer. I think, but our clinicians are getting there. I think we're continuing to work on that. I always have to remind everybody that our healthcare workers, our healthcare providers, were not trained on risk management and risk communication. That's not what they did in medical school or in nursing school. But now we're asking them to do all this. So I think it's a slow, gradual slope. So I hope, Amish, that as this vaccine hesitancy continues to increase, our providers are also getting wiser and smarter with the way they communicate.
Great. So now we've got two audience questions that they're very clinical. So as a clinical practicing infectious disease doctor, I'm going to take the first stab at them, and if people want to add, they can. The first is, how can you distinguish between flu and COVID symptoms? And if someone is infected with both illnesses, can two viruses exchange genes? Are the health effects cumulative? So the short answer is you can't distinguish between COVID-19 and flu without a diagnostic test. I can't do it. No one can do it. They have so many overlapping symptoms, and none of the differences are that reliable that you wouldn't want to test for both or make sure that you're ruling out one when the other, because they're two different treatment pathways. You've got to keep that straight, because if you don't give someone, for example, an antiviral for flu, they could have a worse outcome. The viruses, although they have their respiratory viruses, they come from two different families, so they don't really swap genes. They're not able to do that. But it is true that when people can get co-infected with both of them, and I've seen co-infections, it's unclear whether their severity is worsened there. There's anecdotal reports both ways, because sometimes viruses interfere with each other. So that's that. So those are just really, we need to continue to be vigilant for both and to test for both. And then somebody just asked about co-administering the vaccines. What are the thoughts that clinicians should know? Do they need to be timed? Do they have to be in different arms? No, they don't. They can be given at the same time, which makes it really convenient. And I think LJ had talked about that you're not done yet. If you get your flu vaccine, you need to get your COVID vaccine, and vice versa. That makes it really, really convenient. And there are companies that are actually studying co-formulations with flu and COVID in the same shot. So I'll turn it over to the panel if they want to add anything. I just thought I would handle that clinical question quickly.
I have nothing to add. Thank you so much.
Yeah,
I'll just add that what we're really trying to do at Families Fighting Flu is that obviously we always tell first and foremost your best chance is preventing the diseases by vaccination. But one recommendation we are trying to really say every time we're speaking in front of somebody is to ask for that test, because from a parent's perspective, there have been many times subsequent to Caroline's illness where she had symptoms. We went into, let's say, an urgent care, and they won't test for flu. And I've had to request the test for flu. And I understand they've got a million things going on, but I think two things need to happen. One, there needs to be routine testing. But two, I think the general public needs to recognize that they can ask for that and advocate for their family member and say, look, I realize you may not see flu in the area, but I'm curious to know, could you please test for flu, you know, in addition to strep or whatever else they're going to test in that visit.
I love that, Jennifer. I think that's really important. I think self-advocacy, if we can encourage that, not just for testing, but also for, you know, I want the flu vaccine. Can you talk to me, doctor, about the flu vaccine is important too. It's just, you know, sometimes, like you said, busy clinician, sometimes it falls off the radar. And I think it's interesting because Amesh, you mentioned about surveillance, right? We are really good at emphasizing to third world countries that you need to have surveillance for influenza, because if you don't know you have flu, you don't think it's important. Yet internally in our first world country, we don't really do that great of a job of surveying for our own flu. So I think although CDC does a really, really good job with their networks, I think on the personal level, I agree with you, Jennifer. I really would love to know what I have.
Yeah, I think that's a great point, because I wish patients would say to their doctor when they say, you've got some virus, I wish the patient would say, well, which virus? Because that will lead you down a great pathway to figure out what's going on. It helps with surveillance, public health, lots of things. So the next question is from the audience: how do we address those individuals who believe that last winter there were significant numbers of people nationwide who were diagnosed with COVID, actually had the flu, thus decreasing the incident rate of the flu? Just from my own personal experience, I took care of one flu case over the entire, since this pandemic has, basically since March of 2020. So I think that this is a question that lots of people have, but in my personal experience, there really was very little flu, but I'll let the panel weigh in too.
I can just jump in. CDC has the statistics on the number of tests that were done over the course of the flu season. In fact, influenza testing did not decline. It stayed at least the same, if not went up. So it's not like we tested less. We tested the same. What we did see was very much less positive samples. And so it was about less flu. And it was not about COVID being misdiagnosed as flu.
I think it also just shows the important role that masking to break chains of transmission and social distancing had. And I think as we look at towards this flu season, ensuring that as we continue to vaccinate the American public with respect to COVID and as well as flu, that we be smart and we be safe, because again, these are preventable cases and preventable deaths that we're trying to avoid.
Next question, another good clinical question. Can you say something about the best timing for getting the flu vaccine? How quickly does it wane, and whether there could be a need for a booster depending on how long the flu season lasts? Just my bias towards this is I get my flu shot in October, but the best time to get the flu shot is when you can get it. So if you can only get it in September, get it in September. There has been some data on waning, but it's not enough to change the recommendations regarding the fact that we just need to get a single shot in people, not necessarily worrying about the timing yet, but I'll let the panel weigh in with their own thoughts on that.
Yeah, I completely agree. Get it when you can get it.
Yep, and just to emphasize, if you don't wait to give someone a specific brand of flu vaccine if you got another brand that's appropriate for that person, because you don't want to lose that opportunity to vaccinate somebody either. And as has already been emphasized, ACIP has stated clearly optimal months remain September and October, but they've also stated very clearly that there's benefits to flu vaccination throughout the influenza season, even when there's flu virus circulating. So we can vaccinate in December, in January, in February, right? Remembering more than half of our flu season peaks are in February.
So next question is kind of a bigger, broader one. What can policymakers and providers do to ensure that future flu responses are equitable in regards to resources deployed, access to vaccines and/or treatment, and approach to hesitation and misinformation? Which population should we be targeting to help eliminate disparities in flu vaccination uptake and disease mortality?
I think there are sort of a number of subpopulations to focus on, and we can think about sort of income, we can think about geography, but in terms of racial and ethnic minorities, I think it is worth talking about. I think we've seen with COVID over the last 18 months, racial and ethnic minorities having a disproportionate number of cases because of health inequities, and then a disproportionate number of deaths because of health disparities. And the same can be said with flu. When it comes to seasonal flu, vaccine uptake rates amongst racial and ethnic minorities are lower, yet they have a higher rate of hospitalizations, intensive care units, admissions, as well as deaths. And this is even more striking for kids. So it's kids and adults, but particularly for kids. And so I think we need to continue understanding the health disparities here. And this gets back to sort of trusted messengers, having the right messages and having the right messengers, but really focusing on subpopulations where there are disparities to increase vaccination uptake rates. So we need that for COVID-19. We need that for flu as well.
Yeah, it's definitely something we discuss at Families Fighting Flu quite a bit, and you know, it's a necessity to increase options for all populations to get vaccinated. And I know many times, whether it's a flu clinic or a mobile clinic, or even, you know, if we can continue to you know, increase access to pharmacies. You know, a lot of rural areas don't even have access to a hospital, but they very well may have let's say a Walmart with a pharmacy or a Walgreens. You know, to be able to take your family in to get vaccinated in that area, in that setting, would be a boon. You know, I think it would be tremendously helpful. And I know even since Caroline was sick in 2012, pharmacies, there have been great strides in vaccinating, but I know it changes state to state as far as eligibility and age, correct?
Yeah, most definitely with age, Jennifer, but obviously every pharmacy can immunize 18 and older. But you're right, it does vary from state to state with regards to how far below 18 you can go. I just want to also take a step that I totally agree with you, Jennifer. It's this access. Access is the issue, right? If we can create novel, innovative access points, which we've been learning with COVID-19, you know, we can at least create access and hopefully take that off the table, and then we can work on that trusted messenger and so on and so forth. You know, the final part of that question was about who should we target. And I think we want to keep in mind they're really interesting overlapping populations, right? So chronic diseases such as cardiovascular disease and diabetes and chronic obstructive pulmonary disease are all high-risk conditions for severe complications from flu. And unfortunately, they're also high-risk conditions that are very present across many of our populations, but also in our disparate populations, such as the African American and Latinx populations as well. So I think we really need to focus on those two groups, the African American and Latinx populations, where we have data that show that they're not vaccinated at the same level as, let's say, the white and Asian populations. And then also within that, focus on heart disease, diabetes, and COPD, because those are huge drivers of hospitalizations and of course, death.
All right, so next, I have a question of my own. I'm going to direct it to Anand because he mentioned this. You talked about the fact that you've got metrics that we need to have metrics for preparedness. And one of the things I think that's happened during COVID-19 is we realized that we've got this Global Health Security Index, for example, how prepared countries are. And the US was the most prepared country because we've got the best toolbox. We've got so many tools. How do we prevent our toolboxes from being underutilized? And I think that's probably the biggest lesson that I've taken from COVID-19 as someone involved in this response, is that no matter how great the toolbox is, if we don't have leaders that are willing to deploy it, it's going to end up being bad. It's going to be just as bad as if we didn't have that toolbox.
Yeah, I think you're exactly right. I mean, we can be great on paper, as we were, I think, ranked #1 out of 198, and that's really the difference between capacity and capability. You know, you may have the capacity, but the capability requires, you're right, that the political will, you know, coordination across all levels, you know, following the evidence, acting in a timely fashion. So I think where we really fell short here. I mean, I think that always our pandemic planning could be improved, but it was really the implementation. You know, I started my federal career back in 2005. Actually, I think LJ, that's probably when we first met. And we were focused at that time on H5N1 avian influenza, concerned that would be the pandemic. You know, so it's been 15 years across multiple administrations now, pandemic influenza preparedness. And I think there was a lot of good work done, and some of it was used to respond to H1N1. Some of it was instrumental for COVID. But I think more than the planning, I think, it's really the implementation piece where we fell short. So I agree with you, and I think that has to be part of the equation. So when we think about metrics, it just can't be static metrics focused on capacity. It has to be really doing exercises, doing drills, assessing capability. That will give us more real-time information and data as to how prepared are we really.
And Anna, and if I can also just jump on that and remind us for the seasonal side of it, it is exactly implementation, right? A good friend of mine reminds me that vaccines don't do anything unless they end up in noses and arms.
Yeah, I think that's going to be a major challenge going forward, is trying to figure out how prepared is enough, and how do we assure the same mistakes don't happen again. And with that in mind, thinking about seasonal and pandemic influenza, what do you think the biggest gaps are in the federal government's role right now? Or what would you, if you could change one thing that the federal government does when it comes to seasonal and pandemic flu, what would it be?
I'll let Anand lead off on that one.
Well, I'll just, not to repeat myself, I think I mentioned a couple priorities at the outset, but I think, increasing uptake of the current vaccine, I think, is critical. Over time, continuing to improve the effectiveness of the vaccine. I think we want to do that for all vaccines. Realizing the important interplay between seasonal and pandemic influenza, and continuing to promote the vaccine, not letting it get trapped in the vaccine hesitancy politicization that we've seen with the COVID-19 vaccine, I think is all going to be critical. I think the only other point I'll make is, I went through sort of all the important agencies across the federal government, and there are others who have an important role, but coordination is just so important. ASPR provides that at Health and Human Services. I think the White House is a really important role as well. So fostering coordination and collaboration across the executive branch it's hard, but it's just so important.
I'll just jump in, and Jennifer, I want to just make sure I didn't cut you off there. I'm sorry, but I'm going to just jump in and say it's and coordination across the federal agencies, but then ultimately in the flu sector, right? We've got a lot of stakeholders. I mean, I chair the summit where we have 130 national organizations, all interested in improving influenza immunization rates, and I think the goal there is, and this is where we're working to, because we're not there yet, is coordinating across all our sectors. Because I think we all know what we want to get to, and we all know how to do this. It's just how do we make it the most efficient that we can be, and that is, pharmacy, home health care, long-term care, private clinical practices, emergency departments, hospitals. I mean, we've got all these places that we can leverage, not to mention all these mass immunization clinics that we're now good at doing, right? So how do we coordinate all of that and make sure that there's access is what was key.
Right, so I've got an audience question, which I'll take the first run at because it's something in my field that I've been working on myself. So how can the federal government facilitate development of at-home diagnostics for flu like we have now for COVID? What are the hurdles? So I worked on a big project, and if you just Google my name, right, at-home diagnostics, you'll see a big report I wrote. I was very interested in this prior to the pandemic because I thought it would be really something that would empower people to know their diagnosis, especially for flu, get antiviral treatment, improve surveillance, and improve outcomes. And there were two companies actually that BARDA, which we'd heard about before, the Biomedical Advanced Research Development Agency within HHS, had funded before the pandemic to make these at-home tests. They were PCR tests, and they were moving along pretty well. And the pandemic came along, and a lot of that kind of got pushed aside, but we did end up with home tests for COVID. And I think that there's now a willingness by the regulators to have this happen, because in the past, the only infectious disease you could test for at home was HIV. And that took a company about 10 years to get through the FDA with successive steps, trying to make it simpler and easier and convince the FDA that this could be done safely. But I think this has to be the paradigm, and not just for flu. I think for many other respiratory viruses like RSV, like group A strep, a bacterial infection, all of that could be done because we've shown it can work with COVID. And I think we would really get great benefits. But the big hurdle is actually trying to show regulators that this is something that can be done, that can be done safely, and that they have to be more open to kind of democratizing diagnostic testing. And I think it would go a long way to making us much more resilient to seasonal infections as well as to pandemic threats. But I'll let the panel weigh in if they have any other comments.
Yeah, I just reiterate the fact that it's definitely a need and it's definitely a want in terms of consumers. It's brought up all the time with families that we speak with, that oftentimes their loved one that ended up ultimately in the ER, or maybe didn't even make it to an ER, just wish that they had known, because we all know that the statistics prove that if you test, then you can be on your way to receiving antivirals and ultimately, hopefully better in a few days. So yeah, I think it's imperative. From a mom standpoint, I would totally keep this in the medicine chest next to the Advil or what have you. I mean, it seems like a no-brainer, and it certainly would make it easier for busy parents, right? To be able to test, and then once they see that their child has this, to make sure they get to their pediatrician or the local hospital.
All right,
And you know what? On a surveillance slide, I'd kill for that data. Can you imagine if you can have a real world evidence type study using all these tests where you can test and look at actual incidence and disease? I think it'd be really cool.
So we're approaching the end of our time, so I'm going to take one final question, and we've been asked from the audience multiple questions about getting both vaccines, COVID and flu. So if you can get sick from vaccines, and if there's a better delivery method, needle versus inhaled, just what do people think about that? I'll let you guys handle that question.
I'll jump in real fast. The only bad flu vaccine is the flu vaccines that doesn't end up in you. So take the one you can get, and get vaccinated against the flu. As we now know, and has been mentioned by these wonderful panelists also today, you can get both the COVID-19 vaccine and the flu vaccine at the same clinical visit. So be sure to ask for one or the other. And I like that you're not done yet. You're not done yet. You got COVID coming in for COVID. You're not done yet. What about flu? Coming in for flu, you're not done yet. What about COVID? I think we need to emphasize that, and you can get it both on the same day. And I think that's important.
They just asked a little bit about why do you feel sick after? I'll handle that really quickly. That's your immune system reacting to the vaccine. Your immune system is getting revved up. It's normal to feel some injection site soreness, a headache, have some aches and pains, maybe a fever. That's the vaccine working on your immune system. That's normal. That's not you getting the flu or getting COVID from the vaccine. So I think we're gonna end now, but thank you all for your insights on this important topic. Unfortunately, this is all the time we have for today. I want to thank our panelists for joining us this afternoon, and join us next Tuesday, September 28th from 12 p.m. to 1 p.m. to learn more about pandemic preparedness and lessons learned from the pandemic. Please take the time to complete the brief evaluation survey that you'll receive immediately after the broadcast ends, as well as via email later today. And a recording of this webinar and additional material will be available on the Alliance's website. Anand, LJ, and Jennifer, thank you for joining us.
Thank you.
Be safe.
Yes, thank you.